Welcome back to the Sports Docs podcast. I'm Dr. Ashley Bassett.
And I'm Dr. Catherine Logan.
On each episode, we chat about the most recent developments in sports medicine with experts from around the country. In this episode, we're going to continue our discussion with Dr. Sara Edwards and focus on rotator cuff pathology in the throwing athlete. For many of us, being active isn't just about sport. It's about living fully. But when knee pain or ankle instability gets in the way, it can feel like your body is holding you back.
That's where push braces make a difference. The PushMed ankle brace AcquiFlex and the Push Sports knee brace provide the stability you need without locking you down. Sleek, comfortable, and crafted in Europe, they're built to move with you, whether that means training hard, going for a run, or simply staying strong and confident day to day.
With innovative designs that support while allowing natural movement, push braces help athletes and active people alike find relief, prevent pain, and stick with their treatment so they can keep momentum in their lives.
See the difference at bracelab.com. Clinicians can email samples at bracelab.com and mention the Sports Docs for a free sample.
Are you an early career orthopedic surgeon or fellow eager to expand your expertise? JRF Ortho has some exciting news. Starting early in 2026, JRF Ortho is launching a quarterly traveling fellowship program designed to provide you with hands-on exposure to osteochondral allografts, meniscus, and ligament repair, all in a dynamic and stimulating hands-on environment.
Each fellowship will be led by distinguished faculty with opportunities to learn in different regions across the U.S. Fellows will also get an exclusive behind-the-scenes look at tissue processing with tours at our partner facilities in Denver.
Every quarter, 3 outstanding candidates will be selected for this unique experience, and one of those quarters will be dedicated entirely to an all-female cohort, with both faculty and fellows coming together to advance women in orthopedic surgery.
Applications open this September for the winter program, which kicks off in January. Want to learn more? Reach out to marketing@jrfortho.org. Our conversation picks back up with an article titled Patient Outcomes and Return to Play After Arthroscopic Rotator Cuff Repair in Overhead Athletes. This systematic review, published in January 2023 issue of JOT, analyzed 20 studies comprised of 692 patients with an average follow-up of 40 months. The authors found that arthroscopic cuff repair led to significant improvements in patient-reported outcomes as well as improved shoulder elevation. Overall, 75% of athletes returned to play at a mean of 6.4 months post-op, and 63% returned to their pre-injury level of sport. Complication and reoperation rates were relatively low at 7 and 10% respectively.
Then, from the December 2019 issue of AJSM, we review an article titled Partial Thickness Rotator Cuff Tear by Itself Does Not Cause Shoulder Pain or Muscle Weakness in Baseball Players. This cross-sectional study investigated whether articular-sided partial thickness rotator cuff tears alone produce symptoms in overhead athletes. Of the 87 collegiate baseball players that were analyzed, 47% had ultrasound-confirmed partial thickness tears, yet the rates of shoulder pain and muscle weakness were not significantly different from those without tears. Most of these tears were small, approximately 5 millimeters in depth, and were asymptomatic in 83%. Pain correlated instead with scapular malposition, dyskinesis, and poor total shoulder condition, not the presence of a tear.
We finish up our discussion today with an article titled Internal Impingement of the Shoulder in Overhead Athletes, Retrospective Multicenter Study in 135 Arthroscopically Treated Patients. Patients underwent a variety of procedures, including cuff debridement or repair, posterior glenoidplasty, labral debridement, posterior capsule release, and anterior capsulorrhaphy. Overall, 90% returned to sports, with 52% returning to their prior level at an average of 9 months post-op. Better return to sport outcomes were associated with male sex, presence of a cuff lesion, and simple cuff debridement. Greater tuberosity cysts and anterior capsulorrhaphy correlated with poorer outcomes and higher postoperative pain.
All right, so we're going to shift our discussion now to rotator cuff pathology in the overhead throwing athlete. So, as I mentioned at the start of last episode, we've discussed rotator cuff tears a ton on this podcast, but I don't believe we've actually discussed the unique cuff pathology we see in young overhead throwing athletes, and specifically how treatment of these kinds of cuff tears differ from the traditional rotator cuff pathology that we see in older, non athletic individuals. So, Sara, can you elaborate on the mechanism of cuff tears in throwing athletes? And how do these tears typically differ from those like attritional acute on chronic tears that we see in older non-throwers?
Hey, yeah, that's a great question. So they are very different, right? We see the older patient, will get these kind of chronic
Mhm.
tears that occur usually after the age of 40. But in throwers, it's due to that underlying pathology where they have the tight posterior capsule. So if they're throwing a lot, they develop this GERD complex where it's glenohumeral internal rotation deficit. That's what GIRD stands for. And what that means is they get a tight posterior capsule. So when they go into this late cocking phase, the shoulder, the humerus will shift posteriorly and it will pinch the rotator cuff in between the glenoid and humerus, the humeral head, and then cause these little micro tears of the infraspinatus, sometimes up into the supra, but primarily posterior cuff. And then they can develop pasta lesions, partial articular-sided tears, are the main things that we see in that age. Once in a while, I can think of two in my entire career where I've seen a traumatic cuff tear in a young athlete. And both were from dislocations and high energy football, both, like crashing into each other, but super rare.
And,
Absolutely.
as you indicated, like sometimes there's partial tear development, but we also know, just like a lot of other things in musculoskeletal, sometimes we have something on MRI. It doesn't mean it's actually causing us a problem, like a herniated disc or, whatever it might be. And there's a certain percentage of, asymptomatic partial thickness rotator cuff tears. So up to like 40% have been, suggested in some studies. So, obviously we have to figure out this irregularity that we're seeing on MRI, like how does it match with their exam or their presentation? So like Sara, like how do these athletes typically present to you? Like when you're thinking, all right, they've got a partial thickness tear, but this is actually part of the problem. Like how do you decipher that on their exam?
Yeah, I mean they'll complain of pain. They'll have limited internal rotation on exam. They can have impingement signs. You can sometimes see just classic, Near-Hawks Job tests can be positive. They can have pain with posterior loading of the joint. Like if you do a load and shift test, they'll feel pain posteriorly at times. And then often they'll describe loss of velocity when they're throwing, which is, unfortunate. So.
Yeah.
Good deal.
So we talked a little bit about non-surgical treatment of the throwing shoulder in part one, and I assume there's a lot of crossover, trying to work on that capsule stretch and cuff strengthening and periscapular. So we want to kind of just dive right into surgical treatment in the interest of time. So when you're evaluating these partial tears arthroscopically, what's your threshold for debridement versus repair in a throwing athlete versus a non? Like, does it differ? And then if you choose repair, what's your technique? Like, do you like take down or just tendon? Like, what are you typically doing?
Yeah, really good question, Ashley. I think most of the time I really try not to fix them if I can avoid it. I will debride it, particularly if it's less than 50%. So we use 50% of the tendon width as the number, and the tendon's 15 millimeters wide. So I will just measure it in the OR, like use my shaver, which is usually 3.5 or 4 millimeters, and you put it up there and just kind of gauge, like, okay, this one's 4 millimeters. I'm going to debride this edge. This one's 12 millimeters. That's a problem. And so if it is one of those large, so I use 7 or 8 millimeters as kind of my cutoff. And then if it is one of the larger ones, then I will repair it. I like to take it down, and I know that it's controversial. You can do either. I used to always not take it down, and then I found like they would get super pain, more pain and stiffness. Than if I actually just completed the tear, made a very small hole, or like actually stick a scalpel through the lateral portal and complete it. And then I feel like I can get a better repair and not bunch that cable up as I'm pulling it over. So I like to take the tendon down. How about you guys? What do you do?
I was actually just going to follow up with that because I do the same. I take it down, and I've just always done it that way. So I'm so curious about your experience when you did it the other way. Like you said, they just didn't. Maybe they had persistent pain. Like, so tell me a little bit more about how you're like,
I
oh, I'm not happy here.
Yeah, I find a traditional pasta where you're going trans tendon and preserving the tendon, they get the stiffest. They have a ton of pain. So, and that and really, I think it's a mismatch of the tension. Like you're not setting the tension of the
Yeah.
cuff down, right? Because you have these fibers intact, you're kind of poking through, drop your anchor, and then you're pulling the rest of the fibers down, but you're probably bunching up that lateral side.
Mhm.
That's my theory on why, but no one really knows for sure. But there are a lot of anecdotal reports of pain and stiffness and a really hard time getting back to throwing. So I think they do better if you just
Yeah.
cut them, just complete the tear and fix them.
Yeah.
Yeah.
What about, I don't actually know what you do. What do you do?
Yeah, no, I agree. That's usually what I do. Usually I do complete it, and then I think with the anchors that we have now, like when it was the giant swivel locks, like man, how big of a hole do I have to make? But now we have those, not to just like talk industry, but now we have the fiber tacks that are really small and they're all sutures, and I usually can get that guide right in there and put one, and then just do a repair that way. And I agree. I feel like you're taking tendon and compressing it down where it doesn't actually belong, versus if you complete it, debris that edge can really restore the whole tendon footprint. It sits better with me. And these are usually young people, great vascularity, great tendon quality. They're going to heal. So I'm not worried about like completing and then not going on to heal. So that's typically what I'm doing as well.
This is a patient I'm really careful as well about selection because they don't have a great track record of coming back to the level that they were. So I'm super careful. I make sure we've exhausted all other options before I will take them to surgery for that. And really, they have to be I want them to be like, I can't play anymore. Like, I
Right.
can't play like this. I'm desperate. And usually I'll try injections. I know cortisone shots are totally falling out of favor, but I will sometimes give a cortisone shot in that athlete. Obviously try copious physical therapy.
Yeah.
But I will try all these things before I'll take them to surgery. It has to be like, all right, I'm either I can't do it this way, so I need to do something. And then you tell them like maybe only 15 to 20% of you will get back. It's
Yeah.
not, the odds aren't great.
So, Sarah, I actually have a question. This is not one of the planned questions we had, but you just mentioned cortisone. So I did want to ask you this
Sure.
because I feel like, not like we let insurance drive all of our decision making, but recently there have been cuff cases that have been denied because corticosteroid injections were performed within 3, sometimes 6 months. And they're citing literature saying that there's poor healing in the setting of having cortisone injections. Now, how are you incorporating that kind of data or that concern about cortisone into your cuff population in throwers, but also like non-throwers? Like people want to exhaust conservative treatment, they're in pain, cortisone can help, but then there's these concerns about healing and maybe even denials of the surgical authorization if you
I
give a
didn't
cortisone
know
injection.
that was happening. So
It's happening.
surgeries are
I'm doing
starting to get denied.
peer-to-peers like almost every week now. And I have quite good indications. So for me to do a peer-to-peer, I'm like, what's going on? I finally talked to some guy and he's like, yeah, this new paper came out, and he actually provided me the references. So I was able to look at it. It's a couple articles in JSES. I'll send them to you. But essentially it shows, it's only one study. None looked at partial thickness. And that's my argument I use. I'm like, because I usually don't inject full thickness tears. I'm like, listen, this was a partial. We tried conservative. They need repair. None of the papers you cited look at partial thickness and repairability. They just look at full. But still, like, it's getting a lot of pushback from this, and they're citing these articles. So I'm just wondering how that's changing your practice, if at all.
It has actually. And Seth Gamrat wrote that article out of
Okay.
USC. He's
Yeah.
phenomenal. He's a great researcher, and they showed that when they injected, and then they had a higher rate of failure if that cortisone shot was within 3 months of surgery. So
Mhm.
that's where that number comes from. And so I tell the patients again, like, hey, if you are planning on having surgery, like, we should absolutely not give you an injection in this time period.
Yeah.
And then I will wait, like, even if they, okay, let's try the shot. And I'm like, okay, well, then we're 3 months on the clock. So I am
Mhm.
following those
Yeah.
newish guidelines. I think the data was pretty compelling that,
Yeah.
and some people say you shouldn't inject anybody, anymore. We've got some primary care doctors in our department who are like, no, and they're actually just giving Toradol, which is interesting, just
Hmm.
subacromial Toradol, and they're having pretty good results. So there's some
Interesting.
results now showing just giving subacromial Toradol has a very similar pain diminishing effect and doesn't have the negative effect on the tendon. So kind of interesting.
It's
I'm
really
not doing that. I'm still
interesting.
giving cortisone now and then, but
That
Yeah.
actually is starting to happen in our emergency rooms. So
yeah,
like, because they'd be like, "Oh, I had an injection in the emergency room," and I'm like, "What?" And and then I'd sort of keep being like, "Well, what did you have?" And they'd sort of say, "Oh, I don't know," like it just wasn't. And then I'd go like look at the record from the emergency department, and they're doing Toradol. So I think it must be more in like the emergency primary care literature as
yeah,
more of a staple now.
Wow,
yeah.
I thought all my patients just didn't know what was going on. Like, "You just got an IM Toradol, you don't know what you're talking about." Maybe they're actually giving it subacromial.
That's what I thought. I think they were getting IM, but maybe they are getting it subacromial in the
Yeah.
ER.
Yeah,
I'll have to look back
I
at those
think for
records.
like, I think like a calcific tendonitis that's having a flare that they
Yeah.
would really respond to that, but
Mhm.
you know,
That's
yeah,
so
interesting.
it's interesting. I mean, like we said earlier, things are always changing, and it's
Yeah.
fascinating.
right.
Okay. So, Sarah, you at the start of this mentioned with the rotator cuff tears, like there's other things that are happening. So maybe it's like posterior capsular tightness or capsular laxity, like anteriorly. So when you are in there surgically dealing with a partial rotator cuff tear, do you address those things at all?
I do not.
Yeah.
Good question. So and that's something that's changed
Yeah.
too. So we used to kind of do this posterior capsule. Well, when I was training, people would ablate the posterior capsule.
Yes.
They would take the cautery and just like go crazy. And that, patients had horrible results with that. They would have catastrophic, chondrolysis from that heat being put in there. And then I had a really smart teacher. I remember he would sometimes just stripe the capsule. Like
Mm.
um, he would take a cautery device that was very narrow, like a little hook, and
Yeah.
he would just kind of do some striations to do a release.
Okay.
But I do not. I leave it alone. And so,
Same.
yeah,
Yeah.
yeah,
I wonder, like, I've never, seen a patient who's had sort of like that striping sort of technique, but I think that's interesting, like,
I
just,
think I'm afraid to do it after all the work on chondrolysis after
Yeah.
the burning of the capsule.
yeah,
So,
no, for sure.
Agree. So, being in sports medicine, we want to throw, biologics at everything, right? So everyone comes in wanting a stem cell injection. So are there any promising biologic adjuncts that you have found in your practice that you try for these patients with partial thickness cuff tears? Are you sending them for PRP, BMAC, anything like that? Or are you doing that at the time of surgery to augment healing? Like what role does biologics play in your practice?
I think it's compelling, but I'm not really doing it that much. I think PRP is probably the most compelling right now.
Mhm.
I mean, there's a lot of good data coming out. In the cuff, I mean, a few years ago, like some studies were published that showed it didn't really help in cuff disease so much. It's more in like that mild arthritic patient.
Mhm.
Um, but I have colleagues that do it all the time. And stem cell, I think, is really compelling, but patients ask for it all the time.
Yes.
But I do not. I do not routinely give my patients PRP in their cuff or stem cell. How about
Mm.
you? Do you guys do that like routinely or no?
No, not at all. I
Yeah.
think same thing, like our population in Denver, you get asked about it a lot. It's certainly
Yeah.
not something that I would call routine. Ashley knows I have a little partial rotator cuff tear and I've
Mhm.
thought about it, but I still haven't pulled the trigger for myself. Just kind of doing, the old school PT and seems to be fine. But
Mhm.
yeah, I think, it's promising, but it always just feels like it's hard to sort of say, yep, go ahead and pay this cash. Um, and feel like I'm telling you, this is
Yeah.
definitely going to make all the difference.
Exactly.
Yeah.
We don't really have data to support it right now. And
Mhm.
if anything, it was actually one of your Denver colleagues. He's at University of Colorado, but Jason Dragoo, who
Oh yeah. Yeah.
Mhm.
he published on that. I believe I don't know all the specifics, but it's when he was at Stanford years
Yeah.
ago, and he published that like it actually. And I think he was trying to show that it caused this amazing healing of the rotator cuff, and it actually had the opposite effect. And I was like, oh, yeah, it was one of those studies where I'm like, wow, he's really, doing ethical, good research because there was such a push, like everyone, let's do PRP on everyone. And it was getting
Yeah.
injected in everyone's shoulder. And then he didn't show a significant difference. And if anything, they had a higher re-tear rate. So,
Yeah.
Wow.
but
We really need that literature because I feel like now more than ever, I don't know about you guys in Colorado and in California, but I feel like more and more I'm getting people come in that really want these like I don't know, like more natural treatments or like biologics. And I try to explain like there isn't data to support it. And in that case, like it actually could do more harm than good. And I'm trying to like talk them out of spending their money at our practice. I'm like, it's
I
not going to
know.
help you. And I think we're going to see more and more of that. So I think having data to be able to be like, look, this is not a good indication for this. There are some indications, you're not it. Don't waste your money. Having that data, I think, is going to be really useful as more and more people try to, go towards those. I don't know what you would call them. I call them natural, but
Yeah.
natural remedies as opposed to more, like surgical and things like that.
Like we need the data on the peptides so we can
Yes.
answer
The
the peptide question.
So,
peptides.
Catherine, that you got to tell me what the hits are on that episode because I got asked about BPC 157 like at least 5 times a day, and it's to the point that I rattle it off, and then finally I said to someone, I was like, "Here's the episode. Just go listen to it. Like we talked about this." But it's like a peptide. Sarah, are you familiar with it?
Oh yeah,
You've
I'm
heard,
getting
yes,
asked
yes.
too.
So
It's a hot
everyone's
thing.
asking about it.
You know, in my understanding, correct me if I'm wrong, but it's just like a growth hormone analog. Is that
It is.
right? It's
Yeah,
like,
it upregulates the growth
like
hormone receptors. Yeah.
yeah. And
Yeah.
it's funny that you're saying this because yes, I was checking my chart messages yesterday in Epic. I don't know if you have to use Epic, but patient messaging portal. And a patient had written in and asked about BNP 157. Okay. For post-op, can I take this? And one of the PAs had answered before I got to it. She's like, should be fine, no problem. And I'm kind of like, no, we shouldn't. Please don't recommend that to call her. I'm like, listen, like we don't know that that's safe, and like I just we need to be cautious what we're
Yes.
recommending.
You know what
Mhm.
I don't know and I haven't actually looked into is how much it even costs. Do you guys have any idea?
No, I don't
I
know,
don't
but
even know
a
where they
lot of
get
people
it
must not
from.
be that much because people are taking it like
Yeah.
crazy.
Yes. Yeah. And it's
Getting
very
that
interesting, like the
taxation.
different route. Like sometimes like it's injectable, right? Like it's IM, and then sometimes they're injecting it into the place. So it's like this one guy did a Bankart remplissage on him, and he's like, gym rat. And so like, he really wanted to
It's
do it.
always at
And
some
he's like
dirty gym
injecting
they're
it into
doing
the
it,
shoulder. And
right?
I'm like, I mean, you're 5 months post-op. Like I'm sure it's fine, but like maybe don't. I just, like, would you know where you're injecting it? Like, what are you aiming for? It's very uncontrolled at this point. So, yeah.
There was an article, I want to say in the Atlantic, it was like, or the New Yorker recently, where there was some longevity conference in
Yeah.
Las Vegas, and some doc was giving out peptide injections at his booth, and 2 patients ended up in the ICU because of it. And
Yeah,
so
I've
it kind of
heard
made
about
this
this, I
national
think.
news, like,
Yeah.
hey, are these peptides safe or not? And it got my attention because patients are asking, and we've talked about, I have an interest in perioperative nutrition.
Yeah.
And anyway, I found that really interesting because I was like, okay, so there is some harm here potentially, and you don't know
It's
where the formulation, it's completely unregulated.
it's
So you don't
Yeah.
know
also
where.
wild that someone's injecting anything at a conference.
Yeah.
Yeah, yeah, at the
Yeah.
booth, like all these people were lining up and getting their peptide injections.
Yeah.
So,
Do you
and
know the
then
newest one?
it
Yeah.
was interesting
Oh,
because the
sorry.
doctor running the booth wasn't licensed in Nevada. There were all these issues. It was really, you should read it because, we travel around for our job and
Yeah.
things not to do.
Yeah. Things not to do. Maybe we'll have to do an episode on that article, actually. That sounds
Yes,
fascinating.
definitely.
Yeah,
I'll
it was
look up
good.
that, and I won't take any more of our time up, but that and on ozone injections. Has this
Oh,
hit
I
you
don't know
yet?
this.
I was
Oxygen?
like the air, like up there, like what are you? There's like ozone generators, a machine you can create ozone, and then they inject it. I'm like,
Ozone is
I
just
just,
oxygen,
I
the
know.
3, right? It's like O3.
Mhm.
Yeah.
Yeah,
Wow.
I don't know. I
It's
did a
just
literature
air.
search because my patient
I'm going to
asked
give
me,
themselves
and there's
air
yeah,
emboli.
it's just exactly.
Yeah.
So they always keep us on our toes. We'll never run out of podcast topics because we'll just
Yeah.
always have one to talk about.
It's
Awesome.
good.
All right, so back to our regular scheduling programming.
Yeah. Back to our
So
programming.
yes,
We're going to do the return to play partial, right?
yes.
That's what you
Go
want to
ahead.
dive
Yes,
into
that's where
next?
we are.
Okay. All right. So we want to wrap up the partial cuff injury section with talking about return to play. So, our first paper for this episode reviewed the rate and timing of return to play after arthroscopic rotator cuff repair, finding that approximately 75% of athletes were able to return at an average of 6 months postoperatively. So, Sarah, for your throwing athletes, how do you counsel them as far as like when they're going to return to play, as well as what they should expect about their performance? So, like velocity, like do you expect that they'll get that back?
Right. So I think you have to really caution them that they may not. All right. And then again, it's a last resort option. You may not be the same athlete and maybe only 15 to 20%. There's one study I think it showed 40 to 50% could get back, but I tend to err on the
Yeah.
more conservative side when I'm talking to him. And that, we're doing this to just give it a chance. And then, yeah, I'd say minimum 6 months, but more likely in the night, particularly for a thrower, if it's their throwing side, it's going to be longer than that. And yeah, so I tend to be pretty conservative.
Yeah.
And if they're miraculously back and they've, if their strength is good, the range of motion's back, I don't stop them if they're doing great. But I think the reality is, particularly for a thrower, it's going to be more, if you're doing a cuff, I mean, minimum 6, but probably more likely 9 to 10.
Yeah, that makes
For
sense.
sure.
The
So
higher
Catherine,
level they are, I think it takes them longer to get back to that level, right?
Yeah.
So
If at all.
yes.
yeah, if at all, right? Because they're used to being so elite, and then you take, 1 degree off or whatever, they don't feel the same. So
So we'd like to wrap up today by talking about how oftentimes in these throwers, there's a lot of different pathology that's apparent not only on exam, but also on MRI. And a lot of times you have to address each of those. So Sarah, when there's multiple pathologies that show up on imaging, like a type 2 slap tear, undersurface infraspinatus tear, maybe some contracture of the posterior capsule, how do you decide what the main problem is and what needs to be addressed? Is it a combination of their exam findings at surgery? Like, how do you determine what this person actually needs?
yeah, I think it's a careful history and then a physical exam and see, what is triggering them the most. So that is how I'll determine what is their primary cause. But often they're related, right? So they're dynamically related. So, and I tell them, like, I don't know 100% what is causing your pain, but I think it's this. It seems like it's this. It might be multiple issues. Sometimes I'll choose selective injections. If there's a
Yeah.
spot, I can inject just some lidocaine to see if that alleviates their symptom. You can go in the subacromial bursa, give a little lidocaine and see, okay, does that take all your pain away? Then we know it's coming more from a cuff issue. Again, that posterior capsular, they'll tell you like, oh yeah, that's it. That's when it hurts. And they'll often point to that area. Have them point with one finger where it hurts the most, so yeah, it's a combination of all those things.
Yeah, that makes sense.
Yeah. I think it is hard. Like I think sometimes it's just like you can't always get it done in that first, sort of like you have an MRI and exam and they want all the answers that first day. But sometimes it's like, all right, let's go tackle this a little bit with non-op and see what peels away. And then you start to think about, well, if I address this on the kinematic chain, like what changes and so
Yeah.
It's always hard too, because they do have abnormalities. They'll have a lot of abnormalities on their MRI. So sometimes it's calming them down. Like, I don't, this looks funny, or the radiologist read something, but I think you've had this for a long time and it's probably not the source of your pain. And sometimes it's just counseling them, to make sure that, let them know that's what they have is normal for a thrower.
yeah.
Yeah.
So I'm curious for my last question for you is like, you mentioned that your center, your facility also has like a good amount of technology. Like, what do you see as like emerging technology for like the throwing athletes as like things that you guys are doing that are maybe a little ahead of the curve?
I think I think what's cool, I think the GPS trackers are really interesting that they can wear. That's not totally new, but I think we're getting better at being able to assess what's going on, kind of live, like why they're actually playing a game. They can wear sensors and trackers that are pretty minimal. So you don't have to have a camera facility anymore, right? They can have these little GPS trackers on that can give you good data. So I think that's good. I think we're getting smarter about the rehab and prehab per se, and like, making sure that they're ready. I do think we're still woefully behind with the kids sports. I know you guys know a lot about that, but just the demand on these kids is crazy, and that worries me a lot because that's getting worse. I don't think that's improving at all, despite all the papers and all the education we're out there. And so there's still a ton of demand on kids and this need like to be at 20 showcases and to play 4 games in a day, 3 days in a row, so that I worry about. And I say that as a sports mom. I have 2 kids in sports and we do this, we travel around, we go to all these things. And I'm like, every time I'm like, this is terrible. What are we doing? And I do it.
All right. So fast
Great.
5.
Oh,
Ashley?
yeah. Why not?
Okay. So in the OR, do you prefer foot pedal or hand control?
Foot pedal.
For everything?
Yes.
Okay, perfect. Me too. Okay. What shoes do you wear in the OR?
I wear really comfy running shoes. And I switch them out every few months, but and I keep them there. I don't wear them home, but I just want really good Mizunos with cushion.
What is your favorite OR lounge snack?
Ooh, we have goldfish crackers. That's what I like.
What music do you play in the OR?
I have an old school hip hop playlist. That is my go-to.
Yeah.
And sometimes Journey radio. So we either do like the hip hop mix or Journey.
Yeah. Journey's probably a crowd pleaser. We've been listening to, and it's my athletic trainer who started doing it. It's called Two Friends Big Booty Mix, and there's 26 editions.
I could look for that. Two friends.
Only thing, it's just all remixes. The only thing I'll say is they change songs pretty rapidly. So every once in a while, I've had an anesthesiologist that it was this is too much. But it's so fun because it's a lot of hip hop, but it's they'll mix in rock or just 90s stuff, 80s stuff, and it just across all genres. So it's really fun.
That's great.
Yeah. It's a Two Friends Big Booty Mix.
Okay.
Okay. Last question. What is your favorite surgery?
Ooh. Gosh, that's hard. But I think a really good arthroscopic cuff, a big one.
Yeah. It's
with big multiple anchors, double row, and then you put a patch on and move it around. I love that.
Thank you for listening to this episode of the Sports Talks. We hope you enjoyed our discussion as much as we did. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and YouTube to stay up to date on all things sports medicine. If you like what you hear, please consider leaving us a review or comment. You can also reach us by email at thesportstalkspod@gmail.com or find us on Instagram at thesportstalkspod. We love your feedback. Thank you for listening to this episode of the Sports Docs. We hope you enjoyed the first part of our discussion as much as we did. On the next episode, we'll continue our conversation with Dr. Sara Edwards and shift our focus to rotator cuff pathology in the throwing athlete. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and YouTube to stay up to date on all things sports medicine. If you like what you hear, please consider leaving us a review or comment. You can also reach us by email at thesportsdocspod@gmail.com or find us on Instagram at thesportsdocspod. We love your feedback.